Hello, Dr. Vinod.
Yeah.
Yes, you're live, sir. You can start your presentation now. Thank you.
Okay. Thank you. My name is Dr. Vinod Dubey. I'm a pediatric orthopedic and ortho onco surgeon attached to Kashiba General Hospital and Bhailal Amin General Hospital in Vadodara. So today I'll be speaking on management of idiopathic clubfoot. So the topic I have chosen this specifically because it is a very common problem in India, and still we see a lot of kids with these kind of problems who are neglected, especially in the rural setup and in the remote area in India, and which we can treat with a very simple maneuver if we can diagnose at an early age. So clubfoot basically is uh, congenital deformity which is seen in 1 to 2% in 1000, and it's a congenital dysplasia of all the musculoskeletal tissue below the knee joint. So all the tissues below the knee joint like muscle, tendon, ligament, they all are dysplastic. So here it is only I'm talking about idiopathic, which is like a isolated deformity, not associated with any other neuromuscular anomalies. So etiology to rule out, as I said earlier, the most common is neuromuscular, like any cerebral palsy, spina bifida, spine anomalies, syndromic children, then arthrogryposis multiplex congenita. This is very commonly we miss in our country, and the most common cause for recurrence and untreated clubfoot in India is arthrogryposis multiplex congenita. And then a lot of other dysplasias like diastrophic, Streeter's dysplasia, and Freeman-Sheldon and Mobius syndrome. These are again a few syndromes which are listed in very commonly seen in day-to-day practice, and it's a single musculoskeletal deformity. I mean deformity which is there in normal infants. The infant is absolutely normal, no other anomalies, no brain, spine, everything else is normal. Only they have the CTB deformity, either it is unilateral or bilateral. And this was described well before 400 BC by Hippocrates, and and it has to be differentiated from other deformities like calcaneo valgus deformity, equino valgus, calcaneovirus. So occasionally, we get a call from NICU or from labor room by a gynecologist and saying that it's a CTV, but actually most of the time it is not CTV. It is some other deformities like calcaneo valgus deformity, or it is normal like postural CTV, which is not a deformity at all. So it has to be differentiated because treatment line is different, guidelines are different totally for all different types of deformities. We come to, before going into treatment part, we'll come to like a few basics of CTV, like pathoanatomy. What is the pathoanatomy in this kind of deformity? There are basically four deformity: equinus at the ankle and subtalar joint, then there is a varus in the subtalar joint, and then there is adductors and cavus. Adductors, again, it is there in sternonavicular joint, and cavus in midfoot deformity. This is how the child will present most common deformity. You can see here there is a hind foot equinus, and then the forefoot basically is in flexion and supinated compared to hind foot. So it is something which is very commonly seen, and this has to be differentiated from postural type of deformity. Even kids with postural CTV, they will present the same way, but actually if you try and correct the deformity, it will actually get corrected, while the CTV won't get corrected. These are a few pictures of patient. You can see how it is. It is a basically a trauma for a family, for a expecting mother or the parents who are newly become parents, and the child is born with this kind of deformity, and which is which can be treated if diagnosed early, and it can become as normal as normal kids. So the most common pathology which is seen is basically in talus. Talus basically is a bone. Most common deformity seen is talus and talonavicular joint. So talus is basically shortened. It is short, broad, and it is medially deviated. And neck is short like this. You can see in this picture. Here the left side is the normal side and the right side is clubfoot. Normal side you can see it is The neck is long and broad, and the angle is around 160 degree. Whether if you see the talus in the clubfoot side deformity, it is short, broad, and medially deviated, and these are all same deformity in from superior the end-on view and from the medial side. This is a MRI picture where you can see the talus is deformed and dysplastic. It is the neck is short, it is medially deviated, and you can see it is not the forming the joint between the talus and navicular is not normal. You can see the convexity in the navicular. It is the convexity is lost because it is not articulating with talus in a normal way. And same thing after talus, the most common second bone which is affected is calcaneus. The calcaneus is dysplastic, and all the three facets which are there are dysplastic and flattened. So when talus and calcaneums are deformed, the same way the bone with which they are forming a joint, they're also going to be a deformed bone like navicular and cuboid. And when the joint is deformed, obviously the ligament which is formed by those kind of joints are dysplastic, deformed, and and same thing goes with the muscle. You can see here in the calcaneums how it is, it is short and medially deviated, and same thing happens with the cuboid. Then the joint, the bone which is forming a joint with calcaneum, again it is deformed, and the ligaments around them is it is not normal. It is dysplastic, and it is short on the medial side, elongated on the lateral side. So it is basically one bone is deformed, which leads to second bone, which leads to joints, which leads to ligaments and muscles. Same thing goes with the cuboid. And there are multiple theories which are there in vogue, which describes CTV, which comes and goes with every generation. But the most accepted theory is the primary germplasm defect, which is which is a dysplasia of the cartilage enlarge of the talus and the talar bones in the ankle and subtalar area. Whereas there are other theories like mechanical, neuromuscular, abnormal, peroneus brevis, Hootning theory of dysplasia, Turco. But the most accepted is primary germplasm defect, and second one is polygenic multifactorial. It is a combination of genetic anomalies and environmental issues. So coming to the clinical pictures, again, as I said earlier, the most important thing to rule out is from postural CTV with the idiopathic clubfoot. Postural, there is no treatment. I mean, just you have to reassure the parents and give some manipulation to be done at home, and child will be all right. While CTV, it has to be treated properly. So there are two different line of treatments. Therefore, it is important to differentiate postural from CTV. Again, same thing goes for CVT, congenital vertical talus. It has to be differentiated from CTV because the line of management is totally different from CVT and CTV. Then calcaneovalgus deformity, and there are other abnormalities which need to be differentiated and noted down before doing any treatment. So we come to grading. How do we grade CTV? The most common, there are two kinds of grading we use in India. The first is a Dimerglo score, and the second is a Pirani score. What I use and most of the surgeon in India they use is Pirani score, which is very useful, and it can be done within 1 minute on bedside or in OPD clinic. Whereas Dimeglo score it is done mostly in the European countries, and it takes a little more time, but the inter-observer reliability for both the score are same. So here you can see how they are grading. Basically, the equinus, they are graded. If the equinus is more, the grade is more. If equinus is less, the grade is less. Same thing goes for hindfoot varus. If the varus is more, the score is more. Hindfoot varus is less, the score is less. And they have divided like 45 to 90 degree it is 4 point, then 20 to 45 degree is 3 point, 0 to 20 degree 2 points, and minus 20 to 0 is 1. I mean, 0 is almost normal. 0 to minus 20 is almost normal. So same thing in all these three dimensional, sagittal, frontal, horizontal plane. And then there are a few scores like posterior crease, medial crease, cavus, and poor muscle condition. They each has 1 score. So the maximum score is 20 and minimum is 5, 4. They have graded like benign, moderate, severe, and very severe, and most of the deformities fall in moderate to severe variety. And coming to Pirani score, it is very easy to use, and it can be used by a normal general orthopedic surgeon in a remote place in a district hospital. And it is once you get used to it, you can actually score it very pretty. I mean, in a very nice way, and you can once you get used to it, you can score it within 1 minute. So again, it has two parts. One is hind foot score and second is mid foot score. So the hind foot score is, you can see on the right side, you basically will see the posterior crease. If there are multiple crease, that means it's normal or score is 0. If they have one single crease, 0.5. They have a single very deep crease, then it is 1. And same thing, empty heel sign, you try and palpate the heel, and if you don't feel anything, that means empty heel, or if you feel, it is 1. So there is no 0.5 or partial empty heel sign. It is felt or it is not felt. And then you have equinus. Equinus, if it is beyond neutral, it is 0, and if it is still neutral, 0.5, and it is uh, less than neutral, it is 1. So in this way it is graded, and maximum score is 3, minimum score is 0. And then coming to midfoot score, again midfoot score also, it is, if you see the middle crease, if it is there is no crease, it is 0. If there is single crease, single one superficial crease, 0.5, and it is deep middle crease crossing more than half of the breadth of the foot, it is 1. And then you have curved lateral border. The lateral border is curved at the calcaneocuboid joint, it is 1, and if it is curved at the metatarsal bone, it is 0.5, and it is straight, it is 0. And then you have to feel for the lateral head of talus. If it is not felt, it is 0. If it is partially felt, 0.5, and if it is fully felt, then it is score 1. So again, same way, maximum score is 3 and minimum score is 0. This is again same way how we are scoring. And generally, if the score is 5 or more than 5, it is like severe variety, and there is a high chance that child will require T8 anatomy after correction of the deformity. And if the score is 4.5 or less than 4.54, then you can get away without T8 anatomy. The other clinical feature which has to be documented and looked for is head circumference, upper limb examination, spine, hip and knee, calf muscle atrophy, peroneal muscle, dorsalis pedis artery, and neurological examination. Because these findings are going to tell whether there is a chance of recurrence, whether you can get a full correction, whether the child will acquire different type of bracing, the child will require surgery, whether what are the extra precautions to be taken while putting cast, or if you're contemplating surgery, what are the steps to be taken. All those pictures will come into play when if you do all this examination, and this has to be ruled out before labeling the child as idiopathic CTV. And coming to treatment part, treatment is there are multiple treatment in last 1 century. Different kind of surgeon, different parts of the world have tried different kind of treatment for clubfoot. But in 2003, by International Clubfoot Study Group, they have divided treatment into 3 parts. One by Kites method, second by Ponseti casting, and third is a French technique or Benza technique. What we follow in India, and I personally follow, is Ponseti casting technique. Kites method, I don't have any experience, in Benza technique I have never seen in my career, in India at least. So kites technique, basically it's a 3-point pressure technique where the fulcrum will be at the calcaneocuboid joint. Here the principle is we are going to correct each and every deformity subsequently and sequentially. Like first we'll correct the forefoot adductors, then we'll correct the hind foot varus, and then the last equinus. So you can see actually the average cast required in this technique is more than 20 cast, and which is much more than what we do in Ponsari technique. So each and every time you apply a cast, you are going to correct one deformity, and it is not the correction of deformity sequentially by how we do in Ponsati. And then you have French technique. French, Ben Sahel, he came with the functional method of treating CTV. Here, what he does is they get a therapist who is manipulating the child's feet for 30 minutes, and then he does some stimulation of the peroneal muscle, and then he applies adhesive taping, and this has to continue daily for 2 months and then thrice weekly for 6 months, and this taping will continue till the child is ambulatory, child starts walking, is almost like 1 year. So that the treatment goes on till 1 year, 9 months to 12 months, which is too much for a country like resource staff country like us, where people or kids coming from far area, rural area, they can't come to hospital daily for next 1 year. It's become technically and very demanding from our side to tell them to come daily for 1 year. And then you have the same dressing protocol, and there are different studies which claim that the correction percentage is 40 to 50%, and once we add CPM machine, the correction has improved to 60%. Rest half of the cases eventually require surgery. So still I don't have any experience and I don't use this technique. And the same way how after manipulation for 30 minutes we apply taping in functional method of by Bensa Health. I don't have any experience about this. What we do coming to the most important part is a Ponseti technique. Ponseti technique is a technique which was used by Dr. Ponseti last since 1950s, but it eventually came into uh, known to everybody after 1995. It is landmark papers is showing correction of more than 90%. So here what he does is manipulation of the no of the feet for 1 to 2 minutes, followed by casting above knee, and this casting goes on every weekly interval till 5 to 6 weeks, and then at the end we apply a final cast. If we achieve dorsiflexion, then we can do without T8 anatomy, and suppose if we do not get dorsiflexion, then last cast will be after T8 anatomy. And the sequence of correction will be first is cavus, then adduction, then varus, and then equinus. So there are a lot of people who ask why weekly and why after 1 week, not why not after 1 day, why not after 10 days or 2 weeks, 3 weeks. So there is a science behind it. The basically the efficacy of manipulation and casting is due to viscoelastic property of the ligaments and tendon. So what happens, the ligaments and collagen, they are elastic. That is why we say that the younger the child, there is a high chance of correction to a normal fit. As the child grows older, this viscoelastic property goes down of the ligament. So therefore, a child who is 5 year, 6 year, there is a less chance of him getting full correction compared to a child who is 1 month old. Therefore, you try and stretch the ligament and keep the ligament in the cast for 1 week, and and then there is a constant stress on the ligament in that cast. Once that stress goes, and then there is a called as a stress relaxation phenomena. The tendon relaxes, and it actually assumes that elongated length of the ligament, and then again once the collagen no longer elongates, that is the time we call the child after one week, we remove the cast and we again stretch and again put a cast with the little more stress in the collagen. So every time we call the child, actually we are trying to elongate the tendons and ligaments by properly proper positioning our hand. I'll come to that, where how to do casting and where to all to position your fingers and thumbs in subsequent slide. This is the basis of applying cast every weekly. And also when we go and see under microscope, actually you see wavy nature of the collagen. Wavy nature means there are crimps in the collagen, and when you these crimps will actually allow the ligament to stretch. When you stretch the ligament, actually the ligament can stretch and then crimp disappears, and when again after a few days the crimps reappears. That means the ligament has attained that length. Now crimps again are reappear, and now the ligament is again ready for again sorry, again ready for again next slot of next stage of stretching again. That is why we keep on stretching every weekly, and once the foot gets fully corrected, we apply the final cast. So this is how we manipulate. Actually, in if you remember, we I said in kites method, it's a 3-point method, and where we try and put pressure on the calcaneocuboid joint. Here we are putting pressure on the head of the talus, and we are not actually putting pressure on the calcaneocuboid joint. The reason is, if you put your thumb on the calcaneocuboid joint, you will not allow the calcaneum to evert, and eventually you will not want to correct the hind foot deformity. If you put pressure on the head of the talus, and with the other finger you try and hold the great toe and the forefoot and manipulate. In this manipulation, actually you are trying to evert the calcaneum out of the deformity. The first step is always we try and correct the cavus by supinating the forefoot. Here what we do, with the help of other finger, we try and dorsiflex the first metatarsal or the great toe, and we apply a cast. So actually if you see, after applying first cast, the deformity exaggerate. Now, most of the time, many time parent comes and they are saying the deformity is more now, but actually that is the correct way. You can see this is the first cast. This is the first cast. How you can see, after correcting the cavus, actually you are creating the forefoot into supinated position, so you get more deformity. But actually this is the correct way of applying first cast. And then from here, when from the cavers, then focus shift on the adductors and the hind foot varus. See, the adductors and the hind foot varus correct simultaneously. So if you put a pressure on the head of the talus and you try and abduct by holding the forefoot gradually and without holding the heel. If you see, the left thumb and the fingers actually are not holding the heel. They are actually holding the posterior part of the distal leg, I mean calf muscles. They're not holding the heel, which allows the calcaneum and the talus to correct from varus to normal, or to valgus. And in this way we apply 2 or 3 cast. This is after second plaster. You can see, actually from now we see that the foot is correcting in the correct way. And then after getting full abduction, almost we say it has to be abducted till around 60 to 70 degree. The reason is, in full abduction only the calcaneus is everted. Otherwise, if you try and do tenotomy in less than 40-50 degree of abduction, the calcaneus is not fully everted, and you might end up having some amount of heel varus. And this is after fifth cast. You can see how the foot is abducted around 60 to 70 degree, and now the child foot is ready for tenotomy. So this is after tenotomy. You see how we got 10 to 15 degree dorsiflexion after tenotomy, and it's a stitchless procedure. We can do under GA, or we can do under local in OPD. So how I do it, less than 5 to 6 months of child, I do in OPD under local, and after 6 months, I generally do it in OT under GA, short GA. The reason is that there are two reasons. 6-month child, older than 6-month child is very difficult to handle in OPD, and they keep on moving, struggling, kicking. So it becomes a very tedious job in OPD. And second thing is, less than 6 months giving GA is not good. Basically, we are putting toxins in the developing brain. So I don't prefer giving GA less than 6 months for TA tenotomy. After 6 months, child is bigger and difficult to handle in OPD, and he can be given short GA for for half an hour period to apply cast. So again, same point I'm stressing, dorsiflexion should be done only after achieving 50 to 70 degree of abduction. In that position only, actually the hind foot varus gets fully corrected. This is a cast in different position. I mean, first cast, second, third, and then more after TA tenotomy and full abduction. And then after getting full correction, we give foot abduction brace, and this has to be stressed upon with every visit. The parents come to you in every visit, you have to tell them that after correction the child has to be put in foot abduction brace for next 4 to 5 years. And the protocol goes like first 3 months 23 hours, I mean full time only while bathing or cleaning. You can remove the cast, you can remove the brace, and then otherwise full time in brace for 3 months. And after 3 months, generally what I'll do is 16 to 18 hours, I mean 12 hours in the night and 3 to 4 hours during daytime when child is sleeping. That time you can apply a foot abduction brace. And the position is I mean 70 degree of external rotation. And if suppose if it is unilateral, then the affected side is 70 degree and normal side is 45 degree at the shoulder level with neutral or 10 degree of dorsiflexion. Protocol again, I said the same thing. It has to be continued till 4 to 5 years, and first 3 months 23 hours, and after that it is 12 hours in the night time and 2 to 3 hours in the daytime. And I have seen a lot of kids who come from periphery or from village where somebody has attempted to correct the deformity during the infancy period, but they come at 2 year, 3 year, 4 year period with the deformity, with the dynamic supination. So in those kids, what generally I do, I again go for Ponseti cast. I do casting and I get the foot normal. I cut the deformity both in the hind foot and the forefoot. And once the deformity is corrected, what I do is I do anterior tibial transfer, because that actually no act as an internal sprint, and it prevents the forefoot go into again adduction. Because in clubfoot, in especially in kids who are 3 and 4 years old who are having dynamic supination, actually there is a muscle imbalance. The tibialis anterior is acting more compared to peroneus longus on brevis. So we are going to do tendon transfer, and I generally do with 3 incision technique. And once tendon transfer is done after 6 weeks of cast, uh, 6 weeks of cast, then generally I tell them to without brace, I tell them to walk and do, because now the tibialis anterior is acting in line. It is doing dual purpose. First is dorsiflexion, and second is it also helping in eversion of the foot. And surgery nowadays in Ponseti era, it is very uncommon where we do full-fledged posterior medial release surgery in idiopathic type of clubfoot. I'm not talking about syndromic or neuropathic. Syndromic and neuropathic are different club feet. I'm not talking about that. I'm talking about idiopathic. It is around less than 5% nowadays. We do like full posterior medial release type of surgeries. And in surgeries normally we prefer, and if it is clubfoot syndromic, normally surgery I try and do before less than 1 year. And I avoid less than 3 months, because it leads to very ugly scar, and due to cellular nature of the ligaments and myofibroblast, it not very good outcome if operated less than 3 months. There are different methods of doing incision like Turco, Cincinnati, Carroll, and I do is what is close to Turco method, where we do posterior medial release, and we release the medial structure, medial tendons lengthen, the subtalar and talonavicular joint capsules are released, and then TA tenotomy. and TA lengthening as well. This is a picture showing TL and TAZ lengthening and ankle and septalar joint capsule release. Again, capsule release till tachynofibular ligament to get dorsiflexion and eversion. You can see here, this is a schematic diagram showing different types of ligament, both posteriorly and medially. This is a clinical picture, which is again, no, it's a, we are protecting the posteromedial neurovascular bundle. Once we protect that, and then we release the deep fascia and then lengthen the ligaments, release the capsules, and try and do correction. What I do, I follow a la carte procedure. I do the release and I check on table how much correction I'm getting. Once I'm satisfied with the correction, I stop then and there only. And again, a few pictures showing neuromuscular bundles and ligament and tendon lengthenings. And this is once tanacular joint capsule is released medially, plantar and dorsal side. We try and do correction and then see how much correction we are getting. And of course, surgery comes with its own sets of complication, and if not done properly, you can have these kind of like deformities not fully corrected, or you release too much of ligaments, you get subluxation or valgus deformity of the hindfoot, or if you have very severe deformity, you get very bad scar and stiff ankle and subtalar joint, and you get sometimes the deformity never gets corrected only. So and second, the most common cause is there is a high chance of injuring to neuromuscular bundles. And certain sections of kid, like from children who are more than 6 or 7, 8 years old, who are neglected. And in India, we do see such kind of kids who are coming from far area, like remote area, villages, where they are actually not treated properly, and they think that there's no treatment for clubfoot. And when they come to our clinic, we see like 8 or 9 year old kid having clubfoot, very resistant type of variety. In those subset of kids, actually there is a role for external fixator like Elizaro and just external fixator. I usually prefer putting Elizaro frame on kids who are having clubfoot in more than 6 or 7, 8 year old children who are having a very rigid kind of deformity. And once after 10 years of age, there are combination of things you can do. You can apply cast to loosen up the ligament little bit, and then you can do osteotomies like double osteotomy, triple osteotomies, midfoot osteotomies, talar osteotomies, and triple arthrodesis. These are set of surgeries which basically these are all salvage procedure like triple arthrodesis and talar osteotomies to get the foot plantigrade so that child can weight bear properly and have a normal looking foot. Function wise, it may not be as good as the kids who are treated at a very younger age. So the take-home message is Ponseti is the gold standard for management of idiopathic clubfoot, and any child who is I will recommend children who are 10, 12 years old. You can still go ahead and apply Ponseti cast. By applying Ponseti cast, actually you are reducing the surgical dosing. Basically, if your child is 10-year-old, 7-year-old, 8-year-old, you know that the child will require surgery, but by applying Ponseti, if you cast, 2, 3 cast, you are actually trying to loosen up the ligaments, tendons, and your surgical dosing will reduce. And TA tenotomy and tibial anterior transfer is a part of Ponseti management. Saying that you do TA tenotomy and it's a surgery, no. It's a part of Ponseti management. And according to Ponseti himself, 70% of the time, I mean, the kid will require TA tenotomy. And post casting bracing protocol, it is most important part in successful Ponseti management of CTV. It has to be stressed each and every time the child or the parent comes in your clinic. You have to stress the importance of applying post-op bracing protocol till 4 to 5 years of age. And the most common cause of recurrence is the failure of bracing. Basically, compliance is the most important cause of recurrence. And early detection and management of recurrence of clubfoot gives good functional outcome on long-term basis. So thank you so much for a patient listening. That's
Yeah, thank
the
you
end
so much,
of.
Dr. Vinod.
Mhm.
Yeah, thank you so much, Dr. Vinod. It was an insightful session, sir. Thank you so much for sharing this with us.
Mhm.
And I can see, sir, no question have been posted as of now. So the questions may come later on. You just have to log in your library account and you'll be
Mhm.
able to see all the question of doctors, right? So I thank
Okay.
you on behalf of all the doctors who joined today and from library. And we look forward to host you again in future, sir. Thank you so much for your time.
Okay. There's no doubt at all.
No, no question have been posted, sir. As of now, I can check. But
Okay. Okay.
you need to check your account, sir, where it will come questions on your account. Okay.
Okay. No
Thank you
problem.
so
If
much for
they.
sharing this, sir. Yeah.
Okay.
Thank you so much, sir. Bye.
I can stop sharing now.
Yes, sir. It is over, sir. You can stop sharing. Yeah. Okay.
Okay.
Thank you.
Thank you.